Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Okay, so I think we'll get started. Hello, everyone, and welcome to this week's edition and the last session of the year of Can COVID Speaker Series. Thank you for joining us today. My name is Rosa Staltieri, and I lead the research and evaluations team here at Can COVID, and have the great pleasure of introducing you to this week's speaker, Dr. Olivier Drouin, who is a clinician scientist at the Division of General Pediatrics at the Department of Pediatrics at CHU Saint-Justine. And our title for today is Epidemiology and Outcomes of Children with SARS-CoV-2 in Canada, findings from a prospective pan-Canadian study. So just a few things before we get started. We have saved time at the end of today's presentation for a Q&A session, so please do not be shy and enter in your questions into the events chat, but please do select to everyone when doing so. And as always, we have a brief announcement that we will share at the end. So without further ado, welcome, Dr. Drouin.
Thank you very much for the invite, and welcome everyone. So it's a pleasure for me to share our results of our study. It was recently published in CMAJ, so we'll provide an overview as well as some sneak peek to more recent data. So I have no conflict of interest to disclose. So as you probably know, COVID-19 has affected all age groups across the country since the beginning of the pandemic, but not all have been equal in the disease. I'm lucky enough to work in pediatrics, where there was really only a small proportion of all hospitalizations due to COVID-19 in Canada were in the pediatric age group, and it's not it's not because there are small numbers that people are not worried about them or that we shouldn't study them. And especially as the vaccine are being approved and rolled out, I think increasing attention has been drawn to this age group, as well as specifically factors for more severe disease, which is what we're going to cover today. So our study is titled, as you see there, and as I mentioned just a little while ago, it was published in CMAJ just a couple of weeks back. So for those that want more details, you can find the information there. So how did we conduct this study? So we used the infrastructure of the CPSP, so the Canadian Pediatric Surveillance Program, which is a network of over 2,800 pediatricians and pediatric subspecialists spread across the country that represents the majority of pediatricians in the country. Starting April 4th, 2020, so very shortly after the beginning of the pandemic in Canada, weekly emails were sent to a member of the CPSP through May 30th, 2021, so last summer. In addition, we had representations from all children's hospitals across Canada. So we were able to make sure that we had complete case capture for all children, or the vast majority of children hospitalized with a positive PCR test for SARS-CoV-2. So this particular study was part of a larger research endeavor on the impact of COVID-19 among children. So the results I'm presenting you today are about hospitalized patients with it's actually acute SARS-CoV-2, sorry about that. But there were also two other sections to this project, the one on the pediatric inflammatory multisystem syndrome, which results are being submitted for publication now, as well as endeavor around non-hospitalized patients with acute COVID-19 and chronic comorbid conditions. So again, I'll focus on the first group today. So the data I'm going to present, so the cases were children less than 18 years old who required hospitalization in any hospital across Canada that had acute infection with lab-confirmed SARS-CoV-2. The data I'm going to present today, unless I say otherwise, are up to December 31st, 2020, which is when the data collection ended for the paper that we got published. And of note, the CPSP received funding through the Public Health Agency of Canada, which does not allow reporting data for a cell with size less than 5. So you'll see that spread throughout. And this is obviously to prevent identification of cases for rare presentations. So among the data collected were those there. So the beauty of the reporting and interacting directly with the clinicians was the ability to really collect detailed clinical data around those cases, allowing a more detailed and nuanced analysis compared to lab data or administrative data. So we're really able to own down on the specific of each case. So, and one major advantage we're able to do is looking at the reason for hospitalization. So, whereas our cases including children who were hospitalized with positive SARS-CoV-2 PCR, it became apparent quite rapidly that this was really three different groups of children. The first one were those hospitalized with symptoms that were attributable to COVID-19, so either fever, cough, diarrhea, vomiting. But we also had a sizable portion who were completely asymptomatic and were incidental findings of SARS-CoV-2. So quite early on, many children's hospital, for example, required a mandatory PCR testing of every child who was admitted, or those that required surgery or invasive procedures. So that would include children with fracture or foreign body aspiration who were found to be asymptomatic carrier of SARS-CoV-2, but still required hospitalization. And the last group were those that needed to be hospitalized for your infection control, social reasons. So those include transfers from long-term care facilities, for example. So what results did we get? So from March 2020 to December 31st, 2020, 896 cases were reported to CPSP through the weekly emails. After removing duplicates, we went down to 757. Close to 500 cases reported were actually cases for some of the other two sub-studies I mentioned, so either PIMS or children not hospitalized with chronic conditions, leaving 264 cases that were analyzed for our paper. I'm just going to pause there for a second to make that sink. So during the first 9 months of the pandemic, across the entire country, we captured 264 cases. So that's a very small number. Our best estimate is that represents close to 3/4 of all the cases that were admitted based on lab data. So we had really good case capture, and that was possible because of very small, relatively small numbers. Of those 264, 150 were hospitalized with symptoms compatible with COVID-19. A full 100 were admitted with incidental infection, and a handful were admitted for infection control or isolation purposes. For those who are curious about how did that evolve with the third and fourth wave, so we have data up to May 31st, and obviously this number increased a fair bit, actually, almost doubled when we included data from January to May, but the breakdown looks very similar, with close to 60% were quote unquote true COVID-19, about 40% who were incidental findings, and a handful for isolation infection control. So I won't spend too much time on this slide, but you can see the breakdown by age, population group, as well as region of residence. Representative of what's happening early in the pandemic, Quebec and then Ontario were the source of most cases. What about the clinical presentation of those children? So about 2/3 of kids who were admitted had fever upon presentation. A sizable numbers, especially among the older age group, had gastrointestinal symptoms. Very few actually had the classic anosmia or loss of taste that were reported in adults, so that was an important findings. We also found that lymphopenia was slightly more prominent in the older kids, whereas infants had more rates of neutropenia, and we can see that when it comes to more severe consequence of the infection, so hypotension and organ damage, was a very small proportion of children hospitalized who develop those complications. What about the clinical course and treatment? So among the 150 cases, you can see that a fair number received antibiotics, mostly for, not obviously for SARS-CoV-2 infection per se, but like for coexisting bacterial superinfection. The sickest group received, a fair number received steroids or IVIG, but you can see that, the mainstay of treatment that you saw in adults, including use of antivirals, anticoagulation, was really not the mainstay of treatment for kids. And notably, during the study period, no children was enrolled in a clinical trial, not because there were no trials. There were actually a couple of trials that were open, but since very few children were very sick, the risk of the ratio of risk to benefits, enrolling them in a clinical trial was often not met, and so no children received therapy that was experimental. With regards to severity, we used the Dong score that was developed by a group in China. It was refined by the NIH. You see the distribution between the case differential, between critical, severe, moderate, mild, and asymptomatic. For analysis purposes, we divided them between severe and non-severe. So severe with those with no symptoms, ARDS, macrophage activation syndrome, and organ damage, or that required ICU, whereas severe disease were those with respiratory distress or O2 needs. So all others were considered non-severe. So how many did we get? So out of 150 cases as of December 2020, close to half actually met criteria for either severe illness or critical illness. But when we dig a bit more into what kind of support they required, we find that a fair number actually only required low flow oxygen, and that really a very, very small number required, invasive ventilation or vasopressor, so requiring true ICU level care, despite the fact that 32 needed ICU. And our thinking there is that probably, especially early in the pandemic, we didn't have much data about the evolution of those children. And so many were hospitalized to ICU, not so much for treatment, but for monitoring one-on-one, not exactly knowing how they would evolve. During the study period, very few children died. We had less than 5. And when we looked at, when we compared to what's happening now, it's not that we missed them. As of early this week, there are only 19 deaths in children and young adults, less than 20. So that's a very reassuring data point that we use both clinically and in research to reassure families. So the question that we get asked a lot is, what were the risk factors for those hospitalization and or those more severe diseases? So first thing to look at is age. So if we look at only the children who are hospitalized with symptoms compatible with COVID-19, we see that about the ratio of non-severe to severe for infants, about 2 to 1, so 1/3 having severe disease and 2/3 having non-severe disease. When we look at teenagers, the ratio actually flips. So about 2/3 of teenagers that required hospitalization met criteria for severe disease, and 1/3 for non-severe disease. And when we analyze age by age category, but looking at it continuously, we see exactly the same pattern. So on the y-axis here, you see the adjusted risk ratio for severe disease, and on the x-axis, you see age. And we see clearly that children below 1 fare better than older children. And when we look more specifically, we have another paper published in JAMA Network Open looking at specifically this below 1. When we look at it even more granularly, we see that like maybe the less than 1 month old are a bit sicker, but in general, the 1 to 12 months old do fairly well. The other important aspect that influence severity is the comorbid conditions. So whereas, only 73% of non-severe, that 73% of non-severe had no comorbid condition, when we looked at the severe group, half of those with severe disease had one or more comorbid conditions. So really, despite the fact that comorbidities are fairly rare in pediatric population, those children were really at risk of more severe disease. What were those comorbid conditions that were putting kids at risk of severe disease? So what we did is that we looked at all the comorbidity that you see on the left and compare whether they were more prevalent in the severe disease group versus non-severe. And although the numbers are overall small, what we can see is that it was significant for the conditions that are in the red box here. So chronic encephalopathy with severe neurodisability, obesity, asthma didn't quite meet the bar, although in other reports from the US with larger sample size, we have equivocal findings, and I'll dig a bit more into that in a minute. Other chronic lung disease are definitely a risk factor for severe disease and epilepsy. Interestingly, many of the other ones that were expected, like immunosuppression, didn't stand out as significant, although we cannot rule out that this is due in part to low sample size. This is not from the CMAJ paper. This is newer data. So we, as I said, we continued data collection up to May 31st. And so that with a larger sample size, we find that the following conditions actually are associated with more severe disease. This is very similar to the list I just presented, but with a bit more detail. And so you can see, the same, mostly neurological, respiratory conditions, as well as obesity. And when we look at other disease, including diabetes, metabolic disease, chronic renal disease, immunosuppressions, those actually don't seem to be associated with more severe disease once they're hospitalized. So overall, 55% of children with severe disease had some underlying comorbidity versus 28% in the non-severe group. And when we compare the 2 or more comorbidities versus 0 or 1, we also see a significant difference. And the following conditions I already outlined. The last piece of data I'm going to show you, which is interesting, that this is a paper that was accepted, but it's still in press, is the effect of socioeconomic status. So using the Pampelon index of material deprivation, 1 being the richest and 5 being the poorest, we look at the frequency of hospitalization at our center in Montreal, and we find that there's huge inequalities with regards to frequency hospitalization for COVID-19 in children, with the poorest quintile being vastly overrepresented. When we looked at the details, it just, in the association between this deprivation index and the odds of hospitalization, we see that although it doesn't quite meet the 95% confidence interval, the p-value of P.05, those from the most deprived quintiles were close to 2.5 times more likely to require hospitalization than those from the most privileged quintile. And similarly, the risk of severe illness was, once admitted, was higher in the most deprived group compared to the most privileged group. So the bottom line of the talk, so very few infections with SARS-CoV-2 in children led to hospitalization. Over 40% of those children admitted with a positive test were admitted for other reasons than COVID-19. Half of the cases of COVID-19 in children were hospitalized were severe, but very few required ventilation or hemodynamic support. Adolescents tended to have more severe disease in young children. Any comorbidity, it was associated with more severe disease, but specifically, obesity, chronic neurological conditions, neurodevelopmental disorders, and chronic respiratory diseases, including maybe asthma, jury's still out, are associated with more severe disease. So finally, I want to thank the 2 senior authors of that paper, Dr. Fatima Kakar at St. Justin, Dr. Sean Morris at Sick Kids, as well as Charlotte Moore at Bern and Danny Farrar, and the following organizations for support and funding and references, and I'll be happy to take questions.
Thank you so much. This was a great presentation, and we will get started right now with the Q&A. Just to remind participants, we're going to have about a 10-minute Q&A session, so please do not be shy to ask any questions, and I'd be happy to relay them. So our first question here is, you found that obesity was a risk factor in children for severe disease. In another study, I heard you say parents usually do not perceive their kids as being obese or overweight. How do we then approach this risk factor in protecting overweight kids in the population?
I'm glad that my other type of research is permeating the, the scientific community. It's hard. It's not easy. I think, the Canadian Pediatric Society does recommend using the WHO growth curve. I think I know it's a very touchy subject working in that sphere, but I think there's a good argument for, mentioning, even though the parents may not be aware. I think verbalizing and naming obesity is important. And I think it's important also for those families to know that, for the myriad of reasons why their child may meet obesity, that it is associated with more severe disease. So I think the fact that parents don't necessarily recognize it makes it not less, but more relevant for clinicians to approach the topic with their families, especially with regards to outcomes associated with SARS-CoV-2 infection.
Thanks. So our next question here is, how do you see things changing in terms of findings presented here as a result of the Omicron variant? I know it might be difficult, but perhaps you have any thoughts about that?
Yeah, I mean, I expected the question, to be honest, and the boring answer is that we don't know. We don't know even what it does to adults. There's early signs showing encouraging results that maybe, despite the Omicron variant being more contagious, it might be associated with less severe disease than the other strains. We're definitely keeping an eye on those results. And so far, we are not seeing in other jurisdiction with a larger share of Omicron variant than we have here. We're definitely not seeing a signal of more severe disease in kids. So fingers crossed. The data collection from CPSPs has stopped, but the data collection continues with the impact study that I'm not involved in. But we're keeping track, obviously, of kids' outcome with regards to those new variants.
And I'm sure we'll all keep an eye on when that comes out. The next question is, bacterial co-infections require antibiotics. Did you have confirmed diagnosis, or was it imperial use of antibiotics?
So data was collected from treating physicians. And so we did ask about antibiotics use, but we also asked about specifically the reason for this antibiotic use in any coexisting infections. Those numbers are relatively small. We're looking at them at the moment. I unfortunately don't have the final analysis with me. But yeah, the thinking is that many of those children had true bacterial co-infections that required antibiotics, and that antibiotics were not used specifically for treating SARS-CoV-2.
Thanks. The next one we have here is, are you surprised that children with asthma do not seem to fare worse than those, when they have COVID-19?
We were surprised, and because it made intuitive sense, especially at the beginning, that we would have expected children with asthma to fare worse for two reasons. The first one is that it is a chronic respiratory disease, and SARS-CoV-2, at least initially, was thought of as mostly a respiratory virus. Although it became quite clear early on, and that our findings are actually replicated across jurisdictions. So, and I think I don't think that we've solved the reason why that is. There were some speculation about the ACE2 receptors being differentially expressed in this population. And obviously it's involved in the pathophysiology of SARS-CoV-2, but that was good news because we know that the full 10% of children in general population have asthma. So there's some signals showing that maybe children with asthma with very bad control might not do as well, but definitely for the vast majority who are don't have chronic symptoms or are fairly well controlled, there's no reason to be overly concerned.
Thanks so much. So the next one we have here is, as we're approaching the holidays and families are discussing whether to gather with their extended families and friends, how can parents protect their younger children from SARS-CoV-2, especially if their child has had only one dose of the vaccine?
Yeah, very good question. And it's definitely the topic of many heated discussion at the moment. So the short answer is, well, everyone who is eligible to being vaccinated definitely should be. So that's step one. Step two is that for SARS-CoV-2 and for other viruses, I think contact with relatives who are unwell should be very carefully weighted against the risk versus the benefits. I think our children's hospital right now are filled with other respiratory viruses rather than SARS-CoV-2. The third one is that some jurisdiction add differential access to rapid antigen testing, and those have been used to screen for or to self-screen for either asymptomatic or mildly symptomatic disease. I think that definitely should be part of our arsenal. And the last one is that it is better than last year in terms of the epidemiology of the pandemic, although it is worsening at the moment. So as sad as it may be, it might not be the best time to do the large gathering that everyone is waiting impatiently to have, but maybe keep it into a smaller gatherings.
So our next one here is, did you see any differences in the type of children and outcomes by pandemic waves?
We looked at it. So big caveat here, the data that we have analyzed so far do not include Delta and obviously do not include Omicron. But when we looked at the first versus second versus third wave, we do see a tendency to have more severe cases reported in the third wave. We are not sure whether it's a true signal versus just clinicians being more comfortable treating mild disease as outpatient. I think early on, almost all cases that were mildly sick were hospitalized, many of them to the ICU just for observation. I think as we learn more about the disease, clinicians became more comfortable treating them. That's one piece. The other piece is that early in the pandemic, almost all children with SARS-CoV-2 were hospitalized in one of the children's hospitals across the country. I think as the pandemic continued, many more were comfortable treating them in other centers, more general hospitals. So we might have less good case capture of those cases. So because clinically, we didn't see any greater severity among those hospitalized at our center, but the data seem to suggest that at least in the case that we captured, that might be slightly more severe disease. All the numbers keep on being small.
Right, and we have one final question here, and the question is, when a child experiences a severe outcome from infection, what is the most common mode of transmission? So for example, school, community, sports, activities, household transmission, etc. And has that changed over the pandemic waves?
So I don't think that we've seen a difference in severity based on how the child contracted the virus. I don't think that there's any reason to think that, two children, one who got the virus at school versus one who got it from a parent, there would be a difference in outcome. What we do know is that early in the pandemic, the vast majority of cases, obviously because the school closures, were coming from families, especially families of essential workers. And as the schools reopened across the country, the proportion of cases that were due to sick contacts at school or at daycare increased, and is definitely a large proportion of the cases at the moment. But I don't think that the source of infection is a determinant of, or is associated with more or less severe disease.
Sorry about that. Yeah, thanks so much. That takes us to the end of this session. It's we're about a minute over 4:30. So I just want to take the opportunity here on behalf of the CanCOVID team. I'd like to extend our sincere thanks to you, Dr. Drouin, for presenting to us on such an important topic. And myself, and I'm sure most people in the audience here, will be looking forward to your future data and results. Just to make a few announcements here. This is our last speaker series for the year. So I just want to say I very much enjoyed moderating this year and to see many of you every week. And I definitely learned so much from our speakers and from the great questions and discussions that we got from our audience. And I'm just wishing you, on behalf of the CanCOVID team, a safe holiday season and looking forward to seeing you in the new year. But we are not quite done yet. Please join us for next week's special event. It's the CanCOVID CITF seminar series, and it will be on the impact of COVID-19 disease and vaccination on pregnancy and newborns, which will take place this Monday, December 20th from 11:30 a.m. to 1 p.m. Eastern Time. And that's all from me. I just want to say thanks again. And this concludes today's event. Thanks for joining us, and we'll see you all in the new year.
Thank you, everyone.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.